Hello, everyone. Good evening. Welcome to IVPN Journal Club webinar. We will be starting in 1 minute sharp. Okay. Bismillah ar-Rahman ar-Rahim. Dear respected ladies and gentlemen, Assalamu alaikum and good day from all of you from around the world. Thank you for joining us tonight in the first episode of the season 3 of IVPN Journal Club webinars. Through this series, IVPN Journal Club is committed to share the latest published evidence, learn from high caliber and world-class pharmacotherapy experts in analyzing primary literature, read beyond the trials context, and ultimately optimizing clinical practice. Tonight, we are a gathering of 1,215 delegates from around the world. We are all here excited to learn from our two esteemed guests, Dr. Iyad Ghazal and Dr. Muhammad Yusuf, about the rapidly evolving beneficial roles of SGLT2 inhibitors. This class of medication that was initially discovered and approved in March 2013 for type 2 diabetes management. And then now this class of medications have established their strong presence in the guidelines of cardiovascular and renal diseases, regardless of the presence of diabetes in these patients. I would like to thank the great support of IVPN Journal Club Working Group for their continuous efforts in bringing the finest and high caliber experts and topics to our respected audience. Thank you, dear Umesh and Rinat, for your remarkable efforts to prepare for this event, and to Dr. Osama Tabbara, our mentor and the president of IVPN Network. And without further ado, I will leave the stage now to my brother, Dr. Umesh Kumar, who will moderate this session. Dr. Umesh received his Doctor of Pharmacy degree from the University of Sindh in Pakistan, and currently he's a clinical pharmacy resident at Tapa Heart Institute in Pakistan, and he's proudly one of the cornerstone working group members in IVPN Journal Club listserv. Dr. Umesh, thank you for joining us tonight to moderate this session. Wishing all the best for the speakers and the audience, and the stage, mic, and camera is all yours. Ramesh?
Hello.
Yes.
Can you hear me?
Yes.
Sorry for the ado. Hello and good evening, dear all. And firstly, I would like to thank our brother Ahmed for introducing me so well. And I would like to thank you all for joining us today. So today, moderator, to be honest, I feel too happy to share that these sessions that we are presenting at IVPN Journal Club are proving as a benchmark in teaching and enhancing the knowledge of recent and the experienced pharmacists. So today we have the EMPA trial ongoing. So I would like to introduce our first speaker without making further delays so that we can start with the presentation and start our learning journey. So firstly, our speaker is Dr. Laeed Ghazal. He received his Bachelor's of Pharmacy degree from Ajman University in 2017. Currently, Dr. Laeed is Master's in Clinical Pharmacy candidate in his second year at Gulf Medical University. Dr. Laeed worked as a medical information officer at several pharmaceutical companies in UAE. Currently, Dr. Laeed is a clinical pharmacy intern at SSMC Mayo Clinic. So I would like to invite him to the stage, and the stage is all yours.
So thank you so much, Dr. Umesh, for this kind introduction. And I'd like to thank Dr. Ahmed.
Hello.
Awaini. Hello, can you hear me?
Yes, yes, Dr. Iyad, you can go ahead.
So I'm so honored to be presented today at the IVPN Journal Club, and I'd like to thank Dr. Ahmed Lawaini for giving me the opportunity to give this presentation today. Today, inshallah, I'm going to discuss and talk about the empagliflozin in patients with chronic kidney disease, the EMPA-Kidney trial. The EMPA-Kidney trial was published on 4th of November 2022 at the New England Journal of Medicine. First of all, I'd like to talk about little highlights about the chronic kidney disease. Chronic kidney disease is a progressive loss of kidney function with decreased glomerular filtration rate, GFR, and the presence of the albuminuria. Albuminuria is a risk factor for the subsequent development of kidney failure. So slowing this chronic kidney disease progression will lead to avoiding the dialysis and kidney transplantation, which is highly desirable by the clinician, because the effect of dialysis it's worsening the patient's quality of life, worsening the cardiovascular morbidity and mortality, and it costs too much money for the healthcare system. The need of this study is that SGLT2 has been introduced for diabetes mellitus type 2. And then it showed that it has a high impact in the CKD progression, that patients were having slower kidney disease progression than the patients who did not receive it. So, which triggers the dapagliflozin to be having a clinical trial that measures the slowing of the kidney disease progression, which was the DAPA kidney study. The effect of empagliflozin in those patients with CKD are not well understood. So the EMPA-Kidney trial has been designed to assist for that slowing of the kidney disease progression. So the study objective, the EMPA-Kidney trial was designed to assess the effect of once daily 10 milligram of empagliflozin on the progression of kidney disease and the cardiovascular disease. So it's lowering the progression of kidney disease and reduce the cardiovascular events, and to examine the safety profile of the empagliflozin. The study was supported by grants to University of Oxford from Boehringer Ingelheim and Lilly. So and by funding from the United Kingdom Medical Research Council, the British Heart Foundation and National Institute of Health and Care Research Biomedical Research Council and Health Data Research UK. So the study design and treatment arm. So it was a multicentric, multinational, randomized, parallel group, double-blinded, placebo-controlled trial of the SGLT2 inhibitor empagliflozin. The study was conducted in 8 different countries in Europe, North America, and East Asia, in 241 centers. The number of participants were 6,609. So the study design and treatment arms, first of all, it started by 8,184 patients. Then they went to a screening phase, which was for 15 weeks duration. The patients were assessed at that time to exclude those who are unlikely to comply to their medications, to check the requirement of the SGLT2, either if it's indicated or not, the appropriate dose of renin-angiotensin system inhibitor, is it appropriate or not, and to optimize it. Then there was a randomization visit where patients were randomized to 2 arms. Empagliflozin arm, who will receive 10 mg once daily empagliflozin. The number of participants in that arm were 3,304, and the placebo once daily, the number of the group were 3,305. This follow-up period was at least for 3 years, and the clinical management were assessed by each local doctor. So the trial is actually started on 31st of January 2019, and it was estimated to be completed on 31st of January 2025. But actually, the primary endpoint completion date was 5th of July 2022, and no need to further be studied until 31 of January. So that because of the clear positive results that has been shown by the empagliflozin, So the independent data monitoring committee recommended to stop the trial. So inclusion criteria, all adults more than 18 years old, CKD patients who were at risk of progression, and that was defined by, first of all, before the screening visit, we check 3 months before the screening visit, we check their EGFR, and once they are starting for the screening, we check the EGFR again. So patients were included who were having GFR more than 20 to 45 milliliter per minute, and there was no albumin to creatinine ratio cutoff point. The EGFR, who were having EGFR more than 45 to 90 milliliter per minute, and they were having albumin to creatinine ratio more than 200 milligram per gram. So, and also the patients who were prescribed a clinically appropriate dose of a single agent of RAS inhibitor, unless this treatment was not indicated or not tolerated, was judged by a local investigator. The exclusion criteria was for the type 2 diabetes mellitus patients who were having a prior atherosclerotic cardiovascular disease, functioning transplant, or scheduled donor transplant, polycystic kidney disease. This is the only renal disease that was excluded from the study. Ketoacidosis in past 5 years, and symptomatic hypotension or systolic blood pressure, which was less than 90 or more than 180 milliliter mercury. Patients who were having the LFTs more than 3 times more than the upper limit of the normal range. Patients who were on the intravenous immunosuppression, and pregnant and lactating women, and patients with type 1 diabetes mellitus. So most of these patients who were excluded, they were at high risk, to develop a complication, because even if they were immunocompromised, or they are having no benefit like the patient with type 1 diabetes, as it's mainly immunological. So the primary endpoint was the kidney disease progression, which was defined as end-stage kidney disease, the patients who were started on a maintenance dialysis, or who were a candidate of transplant, patients with sustained decrease in EGFR to less than 10. Most of the studies were less than 15, but because the cutoff point of the inclusion were 10 milliliter per minute higher for this study. Sustained decline of more than 40% in EGFR from the time of randomization, death due to renal disease. And the second primary endpoint was death due to cardiovascular causes. So the secondary endpoints were the first occurrence of hospitalization from heart failure or cardiovascular disease, all-cause hospitalization, death from any cause, composite of first cardiovascular death or ESKD, the components of the primary endpoint tested separately. So let's talk now a little about statistical analysis of the study. So first of all, regarding the power of the study, it was estimated that the first occurrence of the primary endpoint among 1,070 patients will provide the trial with a 90% power at two-sided p-value test to detect that the empagliflozin arm is 18% lower than the placebo. All analyses were done on intention to treat basis, and a Cox proportional hazards regression model was used, Kaplan-Meier, to with adjustment of the baselines to estimate the hazard ratio and the 95% confidence interval for the empagliflozin compared to placebo. The patient baseline characteristics, the demographics and the patient characteristics were equally balanced between the two arms, the empagliflozin arm and the placebo arm. The mean age for both groups were around 64 years old. And as we can see also, the history of diabetes, there were 45% on both groups approximately were diabetics, and 53% in both groups were non-diabetics, and this will show how empagliflozin is having a significant role in slowing the chronic kidney disease even in non-diabetic patients. History of cardiovascular disease, around 25% of both groups were having a history of cardiovascular disease. Here we are showing some of other baselines of the two groups. So the IMPA-Kidney percentage of population, as shown in on the pie chart, the EGFR more than 45% were 21% of the population, EGFR less than 45 milliliter per minute, and having albumin to creatinine ratio less than 200 were 36% of the population, and the percent and 43%, which was the highest percentage of the population, were having EGFR less than 45 milliliter per minute and albumin to creatinine ratio more than 200. The patient baseline characteristics to be completed here only for the cause of kidney disease. The main cause were diabetic kidney disease, and other causes were there as well, but this was the main predominant one. Now let's talk about the results. There was a significant risk reduction in the empagliflozin arm compared to placebo, and it was statistically significant, as we can see from the p-value. So there was a number of events per 100 patients was 6.8 in the empagliflozin arm compared to 8.9 in the placebo arm. So, and even from the secondary outcomes, we had a hospitalization for any cause was statistically significant in the favor of empagliflozin. Here's the results also for the safety outcomes, and none of them were statistically significant. Here is the Kaplan-Meier. So this chart will be giving us the percentage of the primary endpoint during the time of the study. So as we can see, after 1 year of the study, it has been started to see a difference between the two groups, and empagliflozin was statistically significantly reducing the primary endpoints, which was the progression of kidney disease and the cardiovascular events, compared to the placebo. Here was a subgroup analysis for the patients included in the study. We see that in most of this analysis, it was statistically significant, and we had a significant reduction in the empagliflozin arm compared to the placebo. And we can see here that the most effect is happening in the patients who are having albumin to creatinine ratio more than 300. Here is a comparison of the SGLT2 trials that has been accomplished in the last 2 decades. So first of all, the Credence trial, it was a double-blind, placebo-controlled, multicentric, randomized controlled trial comparing the canagliflozin versus the placebo in 2019, and there was a 34% risk reduction in progression of kidney disease. And the second of all, the DAPA-CKD, it was also a double-blind, placebo-controlled, multicentric, randomized controlled trial comparing the dapagliflozin versus the placebo in 2020, and there was a 44% relative risk reduction in the dapagliflozin group compared to the placebo group. And the last study that we are talking about today, the Empagliflozin, there was a 28% relative risk reduction in the favor of empagliflozin. So the limitations of that trial was that we have a lower than expected number of cardiovascular events, which reduce the statistical power of the secondary and tertiary cardiovascular outcome. That's why we can see that most of the secondary outcomes of that trial were not statistically significant, because the number of events were less than the estimated. Relative risk reduction of the primary output was greater in populations with a high level of albuminuria. That's because these patients usually are having a severe albuminuria more than 300 milligram per gram, so they will be having more benefit. That might affect the results of the study. So to conclude that study, empagliflozin therapy led to a significant lower risk of the progression of kidney disease or death from cardiovascular disease compared to placebo. Empagliflozin showed a clear benefits beyond diabetes mellitus in slowing chronic kidney disease progression and cardiovascular outcome. Empagliflozin has shown a significant reduction in all-cause hospitalization. And my conclusion for that, for this presentation, that empagliflozin has beneficial effect on renal function among patients with CKD, regardless the diabetes mellitus state of the patient who are already on appropriate dose of ACE or ARBs. Results are similar to that of dapagliflozin, where dapagliflozin was superior to placebo in improving the cardiorenal outcome in patients with CKD. Beneficial effects noted on cardiovascular mortality and all-cause hospitalization, but not in all-cause mortality. Even though the SGLT2 inhibitors were introduced for diabetes mellitus management, now the trial suggests a clear benefit in the CKD management. The exact mechanism of benefit is somewhat now clear, so these drugs are likely to have a prominent role in the future CKD management guidelines. And this study will be applied on the practice by making SGLT2 a key medication in the management of heart failure and kidney disease, plus the diabetes mellitus, which was the initial indication of the SGLT2 inhibitors. Empagliflozin has proven significant benefits to be used in the management of CKD with or without diabetes mellitus. Empagliflozin will help to delay the need for dialysis for patients with CKD. I'd like to end my presentation by this slide. This is from the KDIGO guidelines for diabetes patients who are having chronic kidney disease and diabetes mellitus. I will just go through one point, that the first line drug therapy is for diabetic patients with chronic kidney disease is the SGLT2 inhibitors. This is because of its benefit for both diseases. And by this, I end my presentation. Thank you so much.
Thank you so much, Dr. Laid, for such a detailed critical appraisal for the EMPA trial. And I believe so with that, we are able to see the significance and the details of the process in this trial. So for further understanding the topic and knowing the significance of this topic, I would like to introduce our next speaker, Dr. Muhammad Yusuf. Dr. Muhammad received his Bachelor's of Pharmacy degree from Ajman University, followed by his Master's degree in Clinical Pharmacy from Queen's University, Belfast. Dr. Muhammad joined Murfak Hospital in 2009, then Sheikh Shakbot Medical City in 2019. He worked in many areas, including inpatient and outpatient pharmacy, oncology pharmacy, drug information center, quality and medication safety areas. Dr. Muhammad is currently working with clinical pharmacy department involved in pharmacy and therapeutic committee, off-label medications use, and leading the pharmacy education program. With that, I would like to request Dr. Muhammad Yusuf to join us on the stage, and the floor is all yours.
Thank you, Dr. Ramesh, for this kind introduction, and thank you, Dr. Ahmed Al-Awaini, and for sure, Dr. Osama, for giving me this opportunity in this outstanding platform, the IVPN. Let me start sharing my slides first. Is it clear now, or can you see it all?
Yes, we can see your slides.
Okay, I think after the nice presentation of my colleague and my brother, Dr. Iyad, he make my mission easy for tonight to talk about the SGLT2 inhibitors, but maybe I will talk in a broad way. I will talk about the heart and the kidney benefits, in addition to the anti-diabetic effect of this group. So, okay, as all you know about the glucose homeostasis in the body, it's have been organized by many organs like the pancreas, the liver, the adipose tissue, the muscle, the brain, the gut, the kidney. And our focus for tonight will be about the kidney, which we have the group which we are talking about tonight is the SGLT2 inhibitors. So as you can see, many different groups or pharmacological groups causing or has this anti-diabetic effect, but the SGLT2 inhibitors mainly, which works in the kidney, and I will explain the mechanism of action in the coming slides. So SGLT2 inhibitors, they inhibit the sodium glucose cotransporter 2 in the proximal renal tubules. We have many examples or many registered medications from this group: dapagliflozin, canagliflozin, and EMPA, which explained well by my colleague, Dr. Iyad, reduces the reabsorption of filtered glucose from the tubular lumen and lowers the renal threshold for glucose. This group is the main, this site is the main site of filtered glucose reabsorption, and reduction of filtered glucose reabsorption and lowering of the renal threshold of glucose results in increased urinary excretion of glucose therapy, reducing the plasma glucose concentration. This is like simply the mechanism of action of this pharmacological group. As we mentioned, we have three molecules: the canagliflozin, the dapagliflozin, and the EMPA. These all are registered and available here in UAE. There is fourth one, ertugliflozin. I'm not sure if it's available in every institution, but my talk tonight will focus on these three molecules which already registered in UAE and I believe in other countries. So for the cana, the initial dose is 100 milligram once daily, preferably in the morning, like the other medications, DABA and EMPA. For the DABA, starting is 5 milligram once daily, and the EMPA is 10 milligram. You can increase the dose for the cana up to 300 milligram once daily after 4 to 12 weeks. For the DABA, the standard dose will be 10 milligram, and for the empagliflozin, 25 milligram once daily. Maximum dose, as we mentioned, 300, 10, and 25. It should be taken early in the morning, and this is because of it has like caloric effect. The AGFR, it should not be taken if the AGFR is less than 30. And for the hepatic impairment, mild to moderate, there is no dose adjustment. Only in severe, it should not be given. So as we know all that chronic kidney disease and heart failure and type 2 diabetes are interrelated, and they are leading to circle of cardiac, renal, and metabolic risk. If we can look here that 24% of patients with type 2 diabetes have heart failure as their first complication. In addition to that, 58% of type 2 diabetes patients also will develop CKD. That's why type 2 diabetes is a main risk factor for heart failure and for the CKD. CKD and heart failure, again, are the most common first complications in patients with type 2 diabetes. So, for example, it's responsible for like 24% for the heart failure and 36% in the CKD, which is almost 60% cardiorenal complications. So now we'll talk about the importance of this group, the SGLT2 inhibitors, in cardiovascular and renal benefits in patients with type 2 diabetes. Just I'll go back to the main trials which have led to the approval of these 3 or 4 medications. For the empagliflozin, we have the, I think it's the very famous one, the EMPARIC trial, and the CANVAS trial or CANVAS program for the canagliflozin, and DECLARE-TIMI for the dapagliflozin, and VERTIS-CV for the ertugliflozin. These all 4 trials have led to the approval of these 4 medications. I just want to highlight that the FDA, after the incidence of the rosiglitazone, you know, all that rosiglitazone has been withdrawn from the market, like I believe 2007 or maybe before, because of the risk of arrhythmia. And after that, and I believe risk of cardiovascular complication, after that, the FDA, in order to approve any diabetic medication, it should be applied for like a program which secures that medication or guarantee that this medication has a cardiovascular advantage, or even it is neutral. It will not cause any problem or any cardiovascular complication. That's why these important trials are the leading for the approval of these all medications. As we mentioned that these 4 trials have cardio and renal outcomes. For the empiric outcome, it has renal outcome. Canvas, Declare, TIMI, and Vertis all was positive in case of reducing the renal-related disease. For the cardiovascular outcomes, I will specify here, or I talk mostly about the empiric outcome, which tested the empagliflozin in addition to standard of care, reduced the cardiovascular risk and improved overall survival in adults with type 2 diabetes who are at high risk. So if you can look here, we have like 14% reduction in the major adverse cardiovascular events, 38% in cardiovascular death, 32% in all-cause mortality, and 35% in heart failure hospitalization. And this was leading directly to the approval of empagliflozin. So the overall safety profile of EMPA was consistent with previous clinical trials and current label information. As we knew all that heart failure is one of the first manifestations of type 2 related cardiovascular disease. After the peripheral artery disease, we'll find that heart failure is responsible for about 14%. Now we'll focus about the heart failure in the beginning, then we can go to the CKD. The SGLT2 inhibitors in the heart failure, they started early with many trials. So as we mentioned, that we have the Canvas program for the CANA, Credence also for the CANA, Declare, TIMI for the dapagliflozin, empiric outcome, which we already explained now, and Vertis CV. This all was in like before, which lead to the approval of these medications. We have the recent trials like the Impact MI, DAPA MI. We have also specific for the heart failure, DAPA heart failure for dapagliflozin, Deliver heart failure for the preserved ejection fraction heart failure. And I believe this trial has been published soon, maybe also like 2 months or 3 months back. We have for the EMPA, the Emperor preserved in the case of preserved heart failure, and Emperor reduced in the reduced ejection fraction heart failure. Impulse, I believe Impulse is still ongoing trial, the results not published yet. And this all for the heart failure treatment. So we'll start with the first one, which is DAPA heart failure. This trial was assessing the dapagliflozin in patients with chronic heart failure who have reduced ejection fraction with or without type 2 diabetes. It was 2 arms, a 1-to-1 randomization, dapagliflozin 10 milligram in addition to the standard of care compared to placebo. The primary endpoint was time to first occurrence of any of the components of the composite cardiovascular death or hospitalization of heart failure or an urgent heart failure visit. The secondary endpoints was time to first occurrence of either of the components of the composite cardiovascular death or hospitalization related to heart failure, and a change from baseline measured at 8 months in the total symptom score of the KCCQ. Also time to first occurrence of any of components of the composite, like more than 50% sustained decline in GFR or reaching the SRD or renal death. But mainly, as we mentioned, the primary endpoint was the hospitalization related to heart failure. And the trial was impressive. It has like a relative risk reduction of 26% and absolute risk reduction of about 5%. Compared to the placebo. We have another trial also, which is the Emperor reduced trial, which examined or studied the empagliflozin and the reduced ejection fraction. And this included patients who are in standard of care, who are using the ACE or ARBs, beta blockers, MRA, ARNI, like Secobacterial valsartan, diuretics. So this all which are the known medications for the heart failure. And it was randomized the patients into two groups. The first group given once daily empagliflozin 10 milligram, and the other arm was placebo. Also, this trial was impressive and significant in reducing the cardiovascular death or the hospitalization related to heart failure, of hazard ratio of about 0.79. We have also mentioned that Imperial reduced, it has what about the safety, which is very important also. The safety profile was similar to the known safety profile of empagliflozin. So there was no difference between groups in the rate of hypotension, hypovolemia or hypoglycemia, and no cases of ketoacidosis. So that demonstrates the safety or the high safety of the empagliflozin. Another trial called the Emperor Preserved Study, which I believe it was published last year, 2021, and it studied the patients who have preserved ejection fraction. So the aim of that trial was to investigate the safety and efficacy of empagliflozin versus placebo in patients with heart failure with preserved ejection fraction. It included patients of type 2 diabetes and non-type 2 diabetic patients aged 18 years old and above, and they have chronic heart failure class 2 up to 4. The randomization, as we mentioned, it was either one arm empagliflozin 10 milligram and placebo. The composite primary endpoint was time to first event of adjudicated cardiovascular death or adjudicated hospitalization related to heart failure. For the secondary endpoint was first and recurrent heart failure and slope of change in eGFR from the baseline. So again, we can find that this trial was impressive, and it has like absolute risk reduction of about 3.3% and relative risk reduction of 21%. And that's why empagliflozin has been approved in the preserved ejection fraction, in addition to the previous trials in the reduced ejection fraction. What about the kidney disease? I think Dr. Iyad, he talked nicely about the trials related to the CKD, but I'll go also quickly about them. So we have the first one, the DAPA-CKD, which was the trial to assess whether treatment with dapagliflozin compared with placebo reduced the risk of renal and cardiovascular events in patients with CKD with or without type 2 diabetes, and who were receiving a standard of care, including a maximum tolerated dose of an ACE or ARBs. So again, it was like one-to-one double-blind trial. Dapagliflozin 10 milligram compared to placebo. The primary endpoint was composite of sustained more than 50% of eGFR decline and ESKD, renal or cardiovascular death. The secondary outcome was composite of sustained also more than 50% of eGFR decline or renal death, composite of CV death or hospitalization with heart failure, and all-cause mortality. As mentioned by Dr. Iyad, that also this trial was, and the DAPA was superior to a placebo and in reducing the cardiovascular, in addition to the ESKD decline. So we have, as we mentioned, DAPA-CKD, and in addition to that, the credence, which also mentioned, this showed beneficial effects on cardiovascular and kidney outcomes in patients with CKD or diabetic KD. So the composite kidney cardiovascular outcome, we can find that the composite kidney outcome, cardiovascular death or heart failure, all-cause mortality, all these trials was positive and impressing in and showing benefit related to the chronic kidney disease. Empagliflozin, which is our talk for tonight, and it's already mentioned by Dr. Iyad, that it's multinational randomized double-blind placebo-controlled phase 3 trial for patients with chronic kidney disease with or without diabetes mellitus. And it's very important to mention that it's with or without diabetes mellitus. And the reason for that, that even maybe in the pharmacy, you will have a patient who have like no diabetes, his HbA1c is the normal, and his all blood glucose levels are normal, but you'll find that he has been prescribed one of the SGLT2 inhibitors like DABA or the EMPA, and that's why you have to know that it's not given for that purpose of diabetes. Maybe it's given for other than that, like for the CKD or for the heart failure. So it's very important to know that and to repeat that it's for patients with and without diabetes mellitus. So again, the dose of the EMPA was 10 milligram and compared with the placebo. And as we mentioned that this trial also was significant. So in this slide, I put all the trials for the renal outcomes, the DABA CKD, for the dapagliflozin, credence for the canagliflozin, and the Empagliflozin, which has been published recently for the empagliflozin. And you can find that all the 3 molecules or the 3 medications have good effect in the chronic kidney disease. This is the last slide, which is that this year ADA standard of care and American Diabetes Association and the pharmacological treatment of hyperglycemia in adults with type 2 diabetes. I know this is a very busy slide. Maybe just I'll focus in few points here. If you go to the left side, we'll find that patients who have established atherosclerotic cardiovascular disease, indicators of high risk, like heart failure, and they have also CKD, recommended independently of baseline of HbA1c and individualized A1c target or metformin use. So we can find here in the left that for these patients, that the GLP receptor analogs, which establish the cardiovascular disease benefit, either or SGLT2 inhibitors with proven cardiovascular disease benefit. So these 2 classes become like a standard of care for patients who have atherosclerotic cardiovascular disease. When you come to the heart failure, you will find only SGLT2 inhibitors with proven benefit in these populations is the standard of care for this group. We'll go to the CKD patients. We'll find that even in the CKD with albuminuria more than 200 milligram per gram, or with CKD patients without albuminuria, in both cases, that is preferably the SGLT2 inhibitors with primary evidence of reducing the CKD progressions, which are the examples which we have mentioned now. And we'll find also that in SGLT2 inhibitors with cardiovascular benefit also has been established. It's written, I think, somewhere. Yeah. Yes, SGLT2 inhibitors with proven cardiovascular benefit are the standard of care, either or GLP analogs with proven cardiovascular benefit. So that will conclude that SGLT2 inhibitors have a great impact in this one, in the management of the type 2 diabetes, especially for patients who have been with CKD and heart failure. Just 1 second, because I think I have to charge my computer. Yes. Okay. And by this, I'm concluding my talk for tonight, and thank you so much.
Thank you very much, Dr. Muhammad Yusuf, for your wonderful presentation. Very, very informative and insightful indeed. Now we would like to open the floor for questions for both Dr. Iyad and Dr. Muhammad Yusuf. Some of the audience are asking for the copy of the presentation. Of course, there will be an email sent to you with a certificate and a link to download both presentations, inshallah. And the recording also will be uploaded on IVPN library within 1 week from today. We'll start to go and get the first question from Mr. Kamal Adam. Mr. Kamal is asking for EMPA, CANA, DAPA, all the SGLT2 inhibitors. Can they be used in non-diabetic chronic kidney disease, even with no proteinuria? I would go to Dr. Muhammad Yusuf, then to Dr. Iyad.
Yes, thank you. Thank you for the question. Actually, as we mentioned here, and maybe I'll go to the slide which mentioned the criteria for the CKD in the last slide. Let me go back for it. Yes, it's here, Doctor. In the American Diabetes Association, they mentioned that for chronic kidney disease patients, they started in the CKD and albuminuria, preferably go directly with the SGLT2 inhibitors, which DABA and CANA. There is no preference actually between any, the guidelines don't give any preference to any one of them. And with CKD without albuminuria, also that it's mentioned that for patient with CKD, eGFR less than 60 without albuminuria, recommend to follow the disease cardiovascular. So you have now two options. One of them is the GL2 inhibitors. So still the DABA or CANA can be used in either groups, either with albuminuria or without albuminuria.
Okay, thank you, Dr. Muhammad Yusuf. Dr. Iyad, you have more input on this point?
Yeah, for sure, there's no further input. Muhammad Yusuf has explained it very well. I just wanted to say that it sometimes also it's excreting more sodium and more glucose by its mechanism of action, which will lead to maintaining a good glomerular like the pressure. It will be that less and more protective in that way as well.
Okay, very much agree on that. Thank you, Dr. Iyad. Dr. Muhammad, there is a question from anonymous attendee. Now let's say part of your daily rounds, Dr. Muhammad, with the internal medicine team or any team you're rounding with, and you want to start your patient on SGLT2 inhibitor. He meets the criteria, and you want to start him on that, him or her. How would you decide CANA, DAPA, EMPA, especially that you showed the well-designed and strong trials for each one of them? How is there any inter-class difference between them that will make you, for this case I would choose CANA, for this case I would choose DAPA?
Yes, thank you, Doctor. Actually, to be honest with you, in my institution, for the time being, I have only the DABA and the Empagliflozin. CANA, we had it before, but now because of these two molecules have that, all these three molecules have the same almost efficacy. So we make a class review and we ended to keep these two medications. To be honest with you, Doctor, both medications given once daily, and they have almost the same safety profile, the same mechanism of action. So from my point of view, there is no preference to use DABA or Empagliflozin. There is no preference for one of them and the other. Maybe the only small difference that for the Empagliflozin, and this I have found it in many references, that you can initiate it for patients who have heart failure or CKD who have eGFR 20 and more. For the DABA, it's 25 and more. So maybe this is the only thing I have to take care about it. If the eGFR is like more than 20, so I can go for the for the empagliflozin, but for the DABA it should be more than 25 the eGFR. So this maybe the only thing which I can take it in consideration in initiating both medication. But we have a lot of patients who are on these two molecules, and the same, to be honest with you, the same like side effects if the patient take it for this medication is the same for the other one. I believe there is no preference for one of them.
Perfect. Thank you, Dr. Muhammad. I have another question for Dr. Iyad. Another attendee is asking, does Empagliflozin have a beneficial role in ESRD? I think he's referring to dialysis, Dr. Iyad.
It's contraindicated for patients who are undergoing dialysis, because as Dr. Muhammad Yusuf mentioned, that it's according to the manufacturer, it's only recommended for creatinine clearance more than 30, and for the practice and experts, they are using it until 25 and until 20 milliliter per minute. This is according to experts and has a great benefit, especially in the heart failure patients. So for below that 20, the patient will be on dialysis. That will lead that he will not be able to take it because it's contraindicated.
Okay. Thank you, Dr. Iyad. Fully agree. Dr. Muhammad, you have any input on this as well?
No, yes, thanks a lot. For sure, we have even they have like good benefit in improving the chronic kidney disease and delaying the end-stage renal disease, but we cannot use it for patients who have eGFR less than 25 for the DABA and 20 for the EMPA. That's why, no, as Dr. Iyad mentioned, yeah, we have to stick to the labeled indications and the labeled criteria.
Perfect. With that, I think in many of your answers, you already answered the other questions that we have. I think we have one last question I just received now from Maya. She's asking about the release of glucose. I think Dr. Iyad alluded to this a while ago. The release of glucose in urine when using SGLT2 inhibitors, is the main cause of severe urinary infections or due to another cause? Dr. Iyad, you can go.
So yes, this is one of the main reasons, because you know that glucose will be at high concentration in the urine, so it will lead, and SGLT2 in general, it's making patients to urinate more. So these two factors will increase the risk of having a urinary tract infection.
Thank you, Dr. Iyad. Dr. Muhammad, when this happens in a patient, do we discontinue permanently the SGLT2 inhibitor and shift, or how do you manage if it's happening recurrent in patients in one patient, let's say on SGLT2 inhibitor?
Okay, really, this is a very good point, Doctor, because unfortunately, this, as we say, this class is very impressive and has great advantage. You know, I call them not anti-diabetic. I call them they are cardiovascular medications with anti-diabetic effects. Yani they have the cardiovascular more than the diabetic effect.
True.
So yeah, unfortunately, this is the problem which we're facing during our rounds in daily, that many patients who have been prescribed these medications, especially the female, and they admitted with the UTI, and we have to suspend this medication till they get, like, for example, this course of treatment for UTI. And later on, actually, we already referring them to the endocrinology. For the majority of cases, the endocrinology will start this medication, but in a lower dose. For example, in the DABA, he will start in like 5 milligram, for the EMPA for 10 milligram instead of 25 milligram, and then he will check the improvement and if the patient will suffer again from the UTI. But for sure, we have to suspend this medication under the admission till the patient takes his antibiotic and cured from the UTI.
Perfect. Thank you, Dr. Muhammad. We have two more questions. I think they are interesting. Is there any benefit for weight reduction for SGLT2 inhibitor, Dr. Muhammad?
Yes, maybe I don't know if I mentioned in one of my slides that one of the big advantages for this medication, I think here, if you can see that, yes, If you go in the middle, that it's minimized. If you would like patients who have like a problem with the weight gain, preferably it's mentioned that GLP analogs for weight loss or the SGLT2 inhibitors. So these two molecules, or so these two groups of medications, have a big advantage in reducing the weight.
Thank you very much. This was a question from Mariam. Another question from Kirtana. Dr. Iyad, did you see in your readings about this topic and your practice during your internship now, the prevalence of hypoglycemia for using SGLT2 inhibitors, especially when we talk about non-diabetic?
During my readings, it came to my within while I'm reading, and it came in a very little case reports, but it's very low. And during my rotations, I did not experience any case of hypoglycemia, because usually they are just eliminating the glucose, but not in that way, that because in the people who are non-diabetics, they will have already the balance between the insulin and the glucagon, so usually they are not experiencing a hypoglycemia.
Thank you, Dr. Iyad. Dr. Muhammad?
I totally agree for sure with Dr. Iyad. As I mentioned, this class has many advantages. Maybe, I have to mention that maybe only the cost is really one of the big challenges of using this class, because as you know, it's very expensive compared to the old generation of sulfonylureas or even the DPP-4 inhibitors. But it has many advantages. One of them that almost there is no hypoglycemia, and this is really a great advantage of this class, in addition to other advantages we have mentioned now.
Thank you very much to both of you, Dr. Iyad, Dr. Muhammad Yusuf. Wonderful presence. Thank you for your great answers for the Q&A. I think it benefited our audience a lot. Thank you for sparing the time and sharing your valuable knowledge with us. And we would really like to see you in future events, inshallah, with the Journal Club and IVPN network activities. And thank you so much. And on behalf of my brother, Dr. Umesh, who had a technical problem, that's why I take over his place for moderating the Q&A. I would like to thank you all, dear esteemed audience, for joining us tonight on this timely, light, and focused event on this important topic. And I'm sure as long during our way on reading and implementing clinical literature and practice in our daily practice, we will see more and more data on this interesting class of medication, as Dr. Muhammad said. So with this, we come to the end of this event. Thank you, everyone, for your presence. And as we mentioned, the certificate, the link to presentation, and the recording will be available within a week from today to check your inbox. And we wish to see you in future events. Stay tuned, and wish you all the best. Thank you so much. Assalamu alaikum.